And so at this time, we are going to open it up for questions. Sidra, people should put the questions in the chat, in the question and answer piece. Is that correct?
Yes, but our panelists have been very efficient at answering those questions. So if there were any questions that any of the panelists think, that would benefit everybody, and they want to discuss it a little bit, then that would be, we could do that too. Go ahead, Dr. Ramaswamy.
Yeah, thank you, Sidra. So the question that came up many times, which I think is a really important one, is this question of both resources for doing implementation science and implementation research work, and also government and institutional support. And I think several of the questions had to do with how do we do all of this when we're working either in government systems that are unsupportive, or that there are donors who are having requirements for implementation on us that don't allow us actually to do this kind of work. And so those are valid questions. And so part of the kind of how we have always thought about it is not that as though a lot of the work that we're doing is immediately is kind of immediately embraced by the governments, and a lot of it is because they don't quite know what it is, and they don't know how it is helpful to them, and they want to make sure that this is not just another research program that somebody from the West is bringing in, and is not kind of really helpful to their cause. So the frameworks. So coming back to the frameworks, the reason that I find the field of implementation science most useful, as Dr. Fernandez mentioned, is that the frameworks and the idea of outcomes and the idea of strategies are a systematic way of thinking about implementation that people have not typically done in the past. So often what has happened is that implementation has been left has been left as the last resort, as something that somebody just needs to do. So I just basically train, and then I'm imagining that everybody is going to immediately implement, and of course that doesn't happen. And so using what I have found is that using some of these frameworks in a thoughtful way to present back to policymakers, to present back to leaders in the government, to be able to show them, okay, so here are some places where there are patient-related factors and community-related factors. Here are some places where there are organizational factors. Here are some places where there are resource constraints. Helping them in a systematic way using the implementation science tools to help them understand where there are implementation challenges and how they can support these challenges, I think have helped to start the conversation going. And without the implementation science approaches, this becomes a very abstract conversation. And so for those of you who are just starting out in this field, just using, or in some cases, what we've done is we've used some of the instruments. Organizational readiness is something that we have used extensively across multiple settings to be able to say, how ready are organizations to implement. So for example, the state government or the district government might roll down a program without really kind of thinking about what does it mean for the facilities in the front line, and what does it mean for the frontline staff. And we've used some of the organizational readiness instruments to take back to the district office, to take back to the state office to say, so here are some challenges that are there on the ground. So before your program rolls out, what are some of the kinds of things that you can do to address these challenges? So the idea is that change doesn't come automatically or immediately or overnight, that this is a slow process, but using some of these tools to help get more insights, both for yourself and as a way of communicating them to policymakers and decision makers, is something that I've found useful.
One of the questions that I saw, and I just provided a brief, I'm sorry, I didn't see that there are several hands up. I'll pause and see Dr. Balasubramanian, and you can go ahead. We'll
okay, no worries. I first wanted to say that Dr. Ramaswamy, your presentation on quality improvement and implementation science was really enlightening. I have sort of grappled on that interface in some of my work as well. And one of the things that I was thinking about and reflecting while you were talking was this idea of building capacity. I do a lot of work in building capacity for primary care practices, because we always hear that primary care, whether in the US or globally in general, is really strapped. Its adaptive capacity is very limited, because it takes it. In general, the scope of primary care is so large, and there's more and more being put in that space. And I thought that it would be useful for our listeners to also be thinking how quality improvement, and in particular continuous quality improvement strategies, can in fact also enhance capacity. And I think that in my experience in primary care, when continuous quality improvement strategies are taught through some support and facilitation and so on and so forth, those also have a lot of sustainability. So in under-resourced settings, the idea that you're doing an implementation project, but also enhancing capacity has benefits for sustainability in the long run, and sort of reducing, again, that translational pipeline and of getting evidence into practice. So I wanted to kind of share that thought to appreciate your presentation, but also to share that with the listeners.
Yeah, thank you. And I must admit that I use your learning evaluation paper extensively, so I found it very useful. I'm happy to comment on that after Dr. Xu, because I do think that's an important point, and I have some insights to share. So after Dr. Xu's response, let me say a few words about that. Thank you.
Thank you, Dr. Rama. I think you mentioned quite an interesting question related to one certain program preferred by a donor. So in a way, our implementation strategy may or may not align with what a donor is thinking. And I think there is sometimes we may have stereotype of think that a donor maybe really want to prefer. For example, the HIV/AIDS program in the past, initially, indeed, there is concern from donor side or from the implementation side. The integrated approach may be going to have negative impact on the outcome of HIV/AIDS patient. So there is the implementation research actually conducted just to address this concern in country like Uganda. And then in the end, they find the vertical clinic used to provide HIV/AIDS service. They can provide the NCD service. The result is the HIV/AIDS, the ARV uptake is still quite high. The HIV patient outcome is still positive. And another positive side is because both HIV/AIDS patient and non-communicable diseases patient go to the same clinic for the same doctor for treatment, the stigma to the HIV/AIDS patient actually reduced because all the patients going to exactly the same area. But then the implementation research in different countries actually also find that there is a situation where you give more tasks to the same clinic, and some task sharing work in one setting may not work in other setting. Depends if the health workers receive appropriate incentive, recognize or teamwork for that particularly setting. So there is many different issues, but the conclusion is the donor, we can work with them to find a window of opportunity to persuade them, even change their way of operation. Thank you. Thank you, Dr. Rama.
Yeah, no, thank you. I agree completely. Maria, should I say a few words to respond to Dr. Vijay's? Yeah, thank you for raising that question about capacity building, I think that is really, really critical. And that's kind of how a lot of the way that we are applying this intersection of improvement and implementation science is playing out. So what we're doing in Ghana, where this is a different program. This is for focusing on neonatal outcomes in tertiary hospitals, is we have our training program is what we call foundational training. And the foundational training is exactly this. It is a mix of improvement and implementation training. And the way that the foundational training is delivered is that we have a baseline training that is delivered to all the frontline staff, all of the midwife and the NICU nurses. And then from the cadre of frontline staff, there are the champions, the implementation champions, who are also frontline staff, who either are kind of self-selected because they want to be part of the implementation effort or happen to be leaders within the different wards. They get the next level of foundational training, which is to think about monitoring how to use data, how to collect, process data, and how to do PDSAs, focused on particular issues that come up in the wards. And so they are the next level up from where services delivered. And so the kinds of training capacity, and it's basically, as Dr. Bijal mentioned, adaptive problem-solving capacity. So think about, we're not going to tell you this is what you need to do, but here's the type way in which you would be collecting data and monitoring. Here's how you plot it on run charts so that you're seeing the trend over time. And this is how you would want to do PDSA type problem solving within your wards. And then the third level of training is the coach training. And these are selected, it's a mix of doctors, nurses, and midwives who receive a more intensive training in the model for improvement and implementation. So the kinds of things that they are looking at is doing both downward and upward communication. So how do you actually do project selection? So cross-ward project selections that might be required for broader scale system strengthening. How do you work with the implementation champions to make sure that they are getting the resources they need and getting the support that they need? We launch a set of implementation or quality improvement projects that actually require more extensive data collection, perhaps some additional work related to identifying, for example, implementation culture. And so they get trained in use of some of the instruments. And then at the final level, we actually do have a leadership training where the training is based around transformational adaptive leadership. So the kinds of things that Greg Ahrens does around implementation leadership. But they are linked in, and then we have this kind of management structure where there are monthly meetings across these multiple levels, so that there is communication that goes back and forth. And so using this model for implementation improvement, not just in a particular context to implement a program, but use it as a general mechanism for problem solving capacity for implementation and improvement is something that we found really useful and that we believe in a lot. So thank you for raising that question.
Great, thank you. There was a question in the chat that has been answered, but I thought I'd bring it up. Someone said they're new to implementation research, been using community groups in our projects, and basically the answer of suitable frameworks for community-based NCD projects. And part of the question had to do with people being displaced under crisis, and I think Dr. Gen provided a reference there. But I wanted to say something about implementation research and implementation practice in community settings. It's very true that many of the models and frameworks and methods, and certainly when we're talking about things like QI approaches, have been developed and tested in clinical settings. And so implementation research, much of the literature does come from the healthcare service sector and healthcare settings. However, also many of these models have now been applied to community settings, so schools, community-based organizations, and churches and other settings that actually don't necessarily involve or include the healthcare system, or sometimes in collaboration with the healthcare system. Nevertheless, I think that there's a lot of work to be done in this area, And I think that there are other disciplines that can help inform the work in this area, including health promotion. And I think that embedded within this question is this the statement about working with community groups. And I know that we've mentioned that briefly, and we'll hear more about that tomorrow. But this is a critical component and element of making sure that the methods and frameworks that you're applying are relevant and applicable to these settings, and doing everything from understanding what influences implementation all the way through developing strategies and evaluating them. That participatory approach is critical. And it's critical for healthcare settings as well, but I wanted to underscore that point when we're working in community settings.
Yeah, absolutely. And if I can chime in, I think the one opportunity in global implementation science work is for more dissemination of examples where using frameworks or an adaptation, say, of the consolidated framework for implementation research to community settings. We need more examples in the literature and disseminated. And I think I would hope that through these 2 days of training and additional technical assistance that we're doing, Maria, that we can also encourage and really encourage folks to contribute to the literature, because we really don't have a lot coming from global settings on adaptation of frameworks for different kinds of things, including for community-based work, for capacity building work, and I think that really benefits other countries as well.
Thank you, Dr. Bala. We had a question come up in the chat that said, how do we deal with political interest versus scientific interest in implementation research? So I know this is a topic that comes up a lot about policy and research, so I thought I'd open it to anyone who's happy to answer.
Yeah, I will punt this to my colleagues, but I will say that, when you look at the trajectory of implementation research, dissemination and implementation research in the United States, this was also not on people's radar. And when I say people, I mean the funders, right? The people who are responsible for making decisions about providing resources to do this kind of work. And I think that one of the things that has influenced and has raised the consciousness of the policies around funding this type of research is the realization that we have what I started with, right? That we are putting so much money into generating evidence and not enough into understanding how to use that evidence. So that's on the one side. That's on the research side. And then on the practice side, there are all these things that are going on that could be, and we know are improving practice, but then these situations are not made generalizable and are not contributing to what we do. So I think that dialogue, that advocacy, if you will, for bridging research and practice is something that has to happen. I am going to turn the maybe other responses over to my colleagues, but I wanted to take a moment and just say thank you all. I am going to have to sign off a few minutes early for another presentation. And I just wanted to thank you so much for your thoughtful questions, for your attention, and absolutely thank you so much for the presenters today. Just really fantastic presentations. And I will see you all tomorrow, turning it over to my colleagues to continue with the question and answer. Thank you.
Thank you, Dr. Fernandez. Did anybody else want to comment on the previous question?
Only to reinforce what Dr. Fernandez says, I don't think that there is, the scientific interest is, at least in implementation research, is very much bound with the political interest, because we are, as in this exactly what Dr. Chu said as well, we're conducting research to be able to use good science to be able to inform policymakers about how to do their work better. And so if we did implementation research just for the sake of doing research, then it just becomes abstract. And as a field that really, by definition, it's about implementation. It has to be linked to what is happening in the field. And therefore, thinking about the right research questions that are helpful to donors or helpful to politicians or policymakers is the way, the kind of your research agenda needs to be framed around that.
And I think in the last webinar we had back in November, we actually had a session on framing your research questions. So, if anybody wants to find out more, then they can refer back to that. So we have a comment in the Q&A which says, I think the strategies that don't seem to work under one area or certain contexts can work for another area at another time after adaptation. So did anybody want to comment further on this? Oh, Dr. Zhu, sorry, I didn't see you had your hand up. Go ahead.
Yes, thank you, Cedra. This also reflect the previous question when they ask research. There is a lot of time we find in a lower middle income country, there is good policy there, but the policy never really put it into practice. And they also have a sort of like a lack of confidence, from the policy maker side, exactly what to do in terms of a practice. So in a way, when you conduct the implementation research, good implementation research actually give the policymakers in a lower middle income country better confidence or better sort of like support to let them move from the policy to the practice in the ground. So I think there is a lot of positive merits compared to, if I say, what is important of clinical research, what is important of implementation research, I would say a lot of implementation research are really, really important for lower middle income countries. Thank you.
Right. So maybe I can take a stab at both of them very briefly. In regards to policy questions, the field of policy implementation science is also growing, and there are more methods that are being developed as we speak to not only implement policy level interventions, but evaluate those interventions and demonstrate benefits at service level, at organizational level, and so on and so forth. So I think there are going to be some resources in that space, or are resources in that space that can be helpful. And I think that as Dr. Ramaswamy and others have said, implementation science is inherently multi-level. We use the social ecological model that go from individual all the way to country level, and all of the interrelated and interacting systems across those levels. And so tomorrow, I hope I'll touch a little bit when I talk about planning and implementation study on the methods to appreciate those interdependencies between levels and study them, perhaps for a policy use or something else. The other question in the chat, Sidra, that you raised was about adaptation, and that a strategy that may not be effective in one context could be adapted and then be effective either in that same context or in a different context. And that is absolutely right, perfectly legitimate. And there are, again, frameworks for adaptation that help you think through how to thoughtfully make that adaptation. What aspect of the strategy are you tweaking or changing in response to what barrier, so that the adaptation can be then more aligned with the new context. And so again, the theory or the framework of adaptation can help with carefully and thoughtfully changing the intervention or tailoring the intervention as a strategy to the new context. So I just wanted to share that.
Thank you, Dr. Bala. I think we are ready to close out for the day, unless anybody had any additional comments.